That is going to, there it is.
It is.
And then we're going to be just kind of talking. This is fairly casual. If you have questions along the way and you want to put them in the chat. I know some people are driving, so if you have a question and you find a break in what we're saying and you want to jump in, that's okay too. But for those of you who are at a computer and can type, you can put those in the chat, and we'll be monitoring that as we go along, and we'll try to get those answered along the way as well. So let's just go ahead and have our speakers introduce yourself. Dr. Stewart, do you want to start?
Absolutely. So first of all, good evening, everybody. I'm happy to be here to discuss value-based care, and excited to kind of share what our practice is like here in the Florida market. My name is Noelle Stewart, and I'm an internist by training. I am the area medical director for Conviva, which means that I supervise several clinicians throughout several different centers in Palm Beach County and the Treasure Coast in Florida. I also take part in strategic planning for our market. And I still do practice medicine. I see patients 3 times a week in our Delray Beach clinic or Delray Beach Center. I've been with Conviva now for 5 years, and in November. And I started my career actually at a federally qualified health center. And for those of you who aren't familiar, FQHCs are community clinics that serve uninsured and underinsured patients. And the center that I worked for in Palm Beach County was funded by our county, which is very unique, and also the federal government, which is more common. And the grants from the federal government were based heavily on quality. And so when I joined Conviva, I was not familiar with value-based care, but after hearing about it and learning and understanding it, it was very similar to the type of medicine I practice in our federally qualified health center. The essence of the practice was heavily focused on quality and very, very close to what value-based care model is, with quality being our top priority. So again, I'm happy to be here, and I'll hand it over to Andrew to introduce himself.
So my name is Andrew. I'm one of the nurse practitioners at Conviva Wellington Family down in South Florida. We were actually acquired by Conviva at the practice I was currently working in, and that was a blessing. We previously did a lot of quantity. I think that was our kind of bread and butter in primary care. And then when Conviva came on board with us, we switched to this value-based care system. And I got to be honest, it's much more comfortable. I'm seeing less patients than I did, but with better quality. I have more time with them. I know much more about my patients than I previously did. I get a bunch of great resources with consult notes that are being sent to me and reviewed. The staff is fantastic. The overall experience has been great. I really enjoy the change of pace and knowing my patients almost to the point where they call me family.
I love that. I always like it when the word family comes up in our world here. So that's great. Well, thanks both of you for doing this. I'm going to go ahead and dive into some of the questions that I wanted to pose to you. And I'll just go ahead and start off with you, Dr. Stewart. I know that as a recruiter, I'm always asking my candidates, do you know what value-based care is? We try to, cover that in our conversations if they don't know. Could you talk about how value-based care specifically addresses the unique needs of geriatric patients that you see in your practice?
Yeah. How about, can I start with kind of what you start with, what is value-based care? Because we can all be on the, even playing field, and I'll make it super basic. So in the value-based care model, providers are reimbursed per member per month. right? And the reimbursement is based on several factors that include patients' demographics, so their sex, their age, and maybe their location. But it also includes their diagnoses, their conditions. And specific conditions have a certain weight, and that weight that is assigned is in essence converted to a dollar value. So whatever dollars you get for that patient based on you identifying and documenting the condition is your quote unquote budget for for the patient's medical needs. So my patient that has end-stage renal disease on hemodialysis, plus diabetes, coronary artery disease, peripheral artery disease, and hypertension is going to be reimbursed at a higher rate than my patient that just has hypertension, right? So we're expecting the cost for the specialists in that end-stage renal disease, the dialysis that's needed, the possible hospitalizations, the procedures. And so we receive a per member per month reimbursement based on all those conditions. So that's, very basic. There's obviously a lot of other nuances, but I think that's good enough just to get the conversation going. So value-based care and how it addresses unique needs of our geriatric patients. When I think about the geriatric population, I really have to consider the 5 M's. So the 5 M's of geriatrics is a framework that we use to help assess our patients. We really heavily focus on that here at CenterWell because we pride ourselves honestly in being senior focused and specialist in senior care. And so what the 5 M's looks at is what matters most to the patient, their medications, their mentation, their mobility, and their multi-complexity. And that can include the social determinants of health, right? And so what value-based care allows us to do is address those needs with additional support and resources, like Andrew was mentioning. We have in our centers nurses that can help us with those really complex patients. And those same nurses will follow the patients once they're admitted into the hospital all the way through inpatient stay, and then follow them for months afterward, for weeks after their discharge. We have integrated home care team that can visit our patients when they just can't make it out of the house. We have high rates of loneliness and depression in our in senior patients. And we have LCSWs that can offer assistance and help manage those patients. And we're just really able to address a lot of the needs outside even of the exam room. We have social workers that can help with food insecurity or housing needs. We give our patients transportation. So I think what value-based care does, it allows us to have all of these additional supports that really probably could not be afforded if it was just a fee-for-service world.
I loved hearing that. I was trying to memorize some of it because I feel like the definition I give is so much shorter, and that was such a nice umbrella effect of everything that is encompassed under value-based care. So that's great. I think that's probably a good segue into talking about maybe the flip side of that. And maybe Andrew, you could jump in here and talk about what the experience is like for patients, maybe who've been more in a traditional model, who come over to the value-based care practice. Could you talk about the challenges and or the benefits? If you could shed some light on that for everybody.
Yeah, absolutely. So most of my career actually has been in non-value-based care, and it's all been fee-for-service. So it's 20, 25 patients a day, as much as you can get in, write the note, send for billing, and move on. And it loses a lot of intimacy. Your patient becomes a number and a patient rather than, somebody who you're truly trying to take care of. The benefit of value-based care, I really feel like I know my patients so much better. with all the extra resources that we have to take care of them with in-house consults, with the specialists that regularly confer with us, with some of the access that we have to some of these extracurricular type programs like the integrated home team, some of the nurses who we work with, the care coaches. I don't know if we call them care coaches anymore, but they are integral. They really fill the gap that I think once the patient leaves your eyesight, that you can still keep tabs on them. You can kind of make sure that there's good communication. And that's so integral in making sure that your patients ultimately get to the outcome that you're looking for and they're looking for. A lot of my patients feel, like I stated before, that when they come in, we're on a first name basis. We're very comfortable with each other. They treat me like family, and I see a lot of the family. Husbands, wives, kids, grandparents. It truly becomes a wonderful experience, both as a provider and as a patient advocate.
And I just want to add to that, the time that we are able to spend with our patients is critical, especially for senior care, because, you aren't just talking to the patients. Like Andrew said, right? You have to talk to the caregivers sometimes, you have to talk to family sometimes. And I don't know specifically if this is just a fee-for-service situation, but I do know at some point I was working as doing telemedicine as well, and often I had patients call in for refills or call in for acute issues because they could not get into their doctor. And that's very different here. So we have open access for our patients, and our patients are able to see their provider or somebody in the office when they need them and how they need them. So if they can't do a face-to-face, we can offer virtual, whether it be audio or tele. And I think that's definitely one of the things that my patients love about, being part of the practice. They also appreciate that we have, in many offices, kind of a one-stop shop. They can see the ophthalmologist and the dermatologist and the podiatrist. In other markets, there's cardiology on board and endocrinology and nephrology at times. And specifically in our market, we also have palliative care, which is so helpful, right, with our patient population. So I think that, overall, the patient's experience is one where they feel like the whole team is under one roof, and they get that specialized patient-centered care.
And then they're more likely to reach out to you or to the practice when there's something happening, instead of just maybe jumping in the car and going to the urgent care or something. Because they have a relationship and they know they have a lot of access and options, then they're more likely to say, let me call first and see what they say.
Right.
So we're kind of talking about how these multiple factors kind of we offer that sort of affects some of their, like, maybe social needs also. You mentioned the LCSW. Could we switch gears and talk about maybe how value-based care has influenced your approach to chronic disease management? Maybe you could just stay with that, Dr. Stewart, and then Andrew can share the same.
Yeah, absolutely. So our regional CMO, Bill Russell, always says, all you got to do is think hard and give a care. And that's really what value-based medicine forces you to do. You've got to think about whether a test, a medication, a procedure, or even a referral to a specialist is in the best interest of the patient, and if it's the best choice for what they want to do in terms of their overall goals for health. Unnecessary and potentially harmful treatments just really don't have, any room here in value-based care. So we look for high value programs and treatments that really can affect outcomes, so that it adds to our patients' quality of life. So in the case of chronic disease management, as we mentioned, we have our high-risk patient management program, and we also have what, you know, chronic disease management program with RNs that follow our highest risk patients, and they provide education and support. And tacked on to the medical needs in those chronic conditions, we have our community health workers that can address some of those social determinants of health and provide them with additional services, be it housing needs or if they have food insecurity. I'd say the other thing is knowing, again, I think because we are not tied to productivity, we have more wiggle room to see patients at a different frequency, right? So we know that the more touches we have with our patients, the better overall when they're super sick or acutely ill. So if I know some practices force you to see, and I'm not saying some practice outside of Conviva and Center will force you to see patients monthly. We trust that our providers know what the most appropriate cadence for those visits are for the patients. And so, yeah, some patients, to take care of those chronic conditions that they may not have a hold on, I might have to see them once a week for a while or every other week. And then it can extend to 3 month, 4 month, on a rare occasion, 6 months, because, our patients are, a pretty sick population. So, so I think that also plays a big role in chronic disease management in the value-based world. And I think the other big thing is, as I mentioned with the health outcomes, we have to be good stewards of our healthcare dollars, and we are always looking for great ways to identify conditions that, if caught and treated early, can reduce the morbidity and mortality. So we have what we call early detection and prevention programs, and patients who meet specific criteria will get screened for certain conditions that, if we manage appropriately, can really make a difference.
Andrew, did you want to add anything to that?
Yeah, I was just touch on the fact that it's really about the outcomes. Our patient outcomes is everything. So whether we see them once every 6 months or once a week or multiple times a week, the opportunity to make sure that those outcomes are achieved is huge. I think all the resources that we're given and the opportunity to make sure that we have adequate supply and time for those patients who are, elderly and have mobility issues or vision issues. Transportation services are available. We have opportunities for the home team to come out depending on their acuity and what type of risk they have, whether it's COPD exacerbations, CHF exacerbations. Just the opportunity to focus on the outcomes has been life-changing, not only for me as a provider, but for the patients that I've dealt with.
I see a question in the chat real quick that I want to see if I can share right now. Maybe you could answer, one of you could answer it. There's a question, could we give a specific example of an early detection flow?
Oh yeah, sure. So we will perform spirometry on patients if they have smoking history, or if they score 5 or above on the CAT score for COPD. One example. We also have we check for peripheral artery disease as well.
So I just want to get that in before I didn't know if it related to something that was in the conversation and I didn't want to miss it. Let me go back to the next thing I was going to ask, and I'll have Andrew jump back in. Because we've been talking a lot about all the things that we feel are very positive and what's happening. Can you think of a challenge or even an innovation, a challenge that you faced when you've been implementing value-based care in the larger healthcare landscape, or if not, what innovations you might like to see developed?
So I think the end result of the outcomes that we keep talking about is really about adherence, and I don't want to use the word compliance. I think that's a really bad word. Adherence to kind of the regimen of care. Um, we can open the door for these patients, but we can never force them to take medications and walk through the door. But through enough sit down time, expressing our concern, being more human to them, they have better trust in us. And I think that has provided a significant shift in the way we practice medicine. I feel like often in a lot of practices I used to work at, it was um, come in, you have a problem, let's deal with it, and you're done.
Yeah.
Now with this kind of EDAPS program and this more of a kind of whole approach to the patient rather than just looking at what their problem is for that encounter has really provided a significant, I guess, a benefit in keeping us, keeping the outcomes in mind. Some of the challenges, of course, you have patient populations as they're aging that become more ill, and the kind of juggling act between multiple specialists, multiple medications, the polypharmacy, focusing on making sure that everybody's on the same page. I get a lot of consult notes from the specialist, and I read everything. When the patient sees me, I already know what's going on with their cardiology appointment, with their pain management appointment. And I got to be honest, there are times where I read them the consult note and they're like, that's not what he said. That's not what they
Mm.
said. And there's a gap. So ultimately, we're like more like in primary care quarterbacks. We make sure that people are getting the appropriate information when they need it. And we have given them opportunities to make sure that their specialists and them are also on good communication. Um, and ultimately, I think that is always going to be an ongoing challenge with this population. The aging population always provides something new that you didn't see coming.
Yeah. And that kind of ties right into the next thing I was thinking about asking, because you mentioned, you've got the aging population. And I know there's a question we need to answer, but I just want to kind of keep this flow on this for just a minute. Aging population, people are getting sicker. So then how do you measure success in value-based care? Maybe success isn't the right word, but what metrics, help you find the most, do you find most indicative of the positive patient outcomes? Do you want to
Yeah, I think
take?
ultimately we have a bunch of different metrics, both subjective and objective. So, we are very data heavy with our data hub processing. So the electronic system, EHR system that we use tracks everything. It tracks number of patients you see, how often you're seeing them, how long you're seeing them. It also tracks whether or not they've had their screenings. Are they up to date with their preventative treatment programs or preventative programs versus just focusing purely on treatment? I think that is a big change of practice that we've kind of shifted towards. It is so heavy on treatment in the fee for service, you really don't get the opportunity to spend time on the prevention side of the story. And that's where your money is. Focusing on things before they happen is less expensive. It is more practical. There are better outcomes and less stress for both you and the patient. And given the opportunity with these early detection and preventative screening programs, we find a lot of things that we didn't even know to look for. I found many times where my patients hadn't smoked in 15, 20 years, and sure enough, they have no breathing problems, but you do a spirometry and you can find evidence that they have some significant obstructive patterns on their breathing. And instead of waiting till they get sick and they wind up with, acute respiratory distress, you have an opportunity to intervene much earlier. Same thing
Yeah.
with the heart failure, with the echocardiograms that we do for the patients with high blood pressure, high cholesterol. I've had many patients who are asymptomatic, and we find hypokinesis on an echocardiogram. We find ejection fraction deficits, valvular pathologies that were much more severe than auscultation on a stethoscope. So these early detection and prevention programs that we have, and the opportunity to spend that time focusing on them, I think is has been nothing but amazing all the way through.
Yeah, and I'd like to add to that. So, in addition, for me, I think success really is about how many healthy days my patients have. The more healthy days, I feel the more successful we've been in what our goals are for them. And when I'm looking at metrics and considering, in the value-based care world, is this working? I'm looking at things like our acute inpatient stays, reducing that, our ER utilization, our readmission rates. And I also, we have, like Andrew said, we have pretty great data analytics, and we're also able to identify what we call care triggers, where there may be some higher risk medication prescribing. So, kind of taking a look at everything, if I see that there's high inpatient admissions, I'm thinking, are my patients not engaged in their health? Are we not giving them enough touches? Are we not identifying the changes in their status? Or are they having uncontrolled conditions? And if I see high ERs, are the patients not getting the access that they need? Do we need to look into maybe virtuals or audios for them because they can't get into the office? We mentioned the in-home that we offer. And I think the other indicator is, like I said, the high risk medications. So are we deprescribing well in our senior population? Because opiates, benzos, the sulfonylureas, the insulins, they can all be pretty deleterious to the health and the well-being of our patients. So, making sure that's being addressed. And then, of course, we have net promoter scores surveys that our patients take after their visit. So it's nice to know how patients perceive the care that they're receiving, and what they think about the services that we're offering. And so, overall success looks like, reducing all of the avoidable acute episodes. It's patients being really engaged in their health goals, and in how to get to those health goals, and having strong relationships with their providers where there's a lot of trust, and where the patients really feel cared for, and then more healthy days.
So I want to stop for just a second and answer a question in the chat. We have a question about referrals, and are referrals to palliative care early in the disease process?
I'm sorry, can you repeat that?
Yeah, are referrals to palliative care early in the
Palliative.
disease process? Like, I guess, do they take place early in the disease process?
Oh, right. So with our palliative care, the first conversation is about what matters to the patient, and again, what their goals are. So palliative we use if we know that a patient is nearing end stage, and sometimes actually we will refer patients to our palliative docs so they can have deeper conversations about their end stage diseases, and offer prognosis and give them kind of their options in terms of what life can look like if they select different paths. So I wouldn't say it's early in the disease process, more towards the end of the chronic conditions, before hospice.
And I'm going off script a little bit about where we are, just because I thought of something while you all were talking. Maybe you can address this, Andrew. We're talking a lot about relationship building and spending time, and what do you think is sort of the special sauce, and how Conviva Centerwell is good at making that work between the providers and the patients, and having them take some ownership for their care, and building that trust with us? Do we have any thoughts about that?
Yeah, I think that's the key word, trust. Ultimately, your patients If they don't think you care, the chances are that, it goes in one ear, out the other. When you actually come from a place of not do as I say because I'm, the medical provider and I know more and you should do this, but you come from a place where you give them clear understanding and, almost empathy and sympathy in these situations, the ability for them to change behavior seems to be more, I wouldn't say aggressive, but more likely to happen. Outcomes are always kind of our end goal here with all of our patients. And like I stated earlier, you can't make them do anything. But often, showing them that you care, that you trust them and they trust you, and ultimately being available for communication. When my patients have questions, I encourage them to call the office and I tell them, listen, you call the office, you may not be able to speak with me immediately, but if you call and you have a question or a concern or there's something happening, please give us that information. That message will get to me and I can quickly either respond through another message or by the end of the day, I will call you back. So having that communication, that open communication, seems to be the biggest turning point in getting patients to really focus on their own health outcomes.
Yeah, and sort of us helping them to trust, to know when to call and talk to someone. And so I think it does all come back to trust, like you said. I want to switch gears back for just a second. And we do have another question I see in the chat. About, you said something and had used the word data analytics, and it made me want to talk about technology and what role technology plays in supporting the practice and the patient outcomes. Could you talk about that, Dr. Stewart?
Yeah, so we briefly mentioned our data hub or the data analytics, and it's pretty robust. It gives providers a great bird's eye view of their patient panel, and they are able to drill into areas that are, maybe of more concern or interest. We have the ability to see a patient's medical economics. We can look at the patient's quality indicators or their HEDIS measures. Most of you all are probably familiar with that. And we can look at what we discussed a little bit, the EDAPs, the early detection and prevention programs that we have. We can look at those quality indicators as well. And so we have a lot of really good information. We can look at referral trends, and this is available to everybody. We can look at what was the care triggers, where we're looking at like high risk medications, and you can pull up a list of all your patients with an A1C below 6.5 or 7 and see who is on insulin. Do they, really still need that insulin? So it's a great population health tool. And it really helps you to identify those patients that need maybe higher touch frequencies, or maybe additional resources or support. They could maybe benefit from having our pharmacist speak to them, or our care navigators talk to them. And we also have generative AI. And in our systems, the way that we're currently using it is to help identify previously documented diagnoses that we may not have captured. Right. So these are diagnoses that may have come from claims data, or they may be hidden in a specialty note or a hospital note or a diagnostic impression. So that's also very helpful for new patients that may not know, may not be well versed on their medical history, but also with established patients who, may have had an acute episode or seen a PPO patient that went and saw 10,000 specialists, and you have no idea what conditions were diagnosed at those specialty visits. So right now, that's how technology is helping us. We are currently piloting an ambient AI where the software works by picking up the conversation between the provider and the patient, and it's able to construct, you know, a visit basically. So I'm looking forward to that. I'm not part of that pilot, but I am super excited to see what comes of it.
Okay. Thank you. I'm going to jump into the chat just for a second and ask a question. The question is, how are diagnostics affected with value-based? Is there an adherence to a certain guideline for how frequently a certain diagnostic should be performed, or is there still freedom to make those decisions?
Yeah, definitely freedom to make those decisions. The only guidelines I would say is, you know, when we're talking about age-appropriate screenings, you know, I think that we are always supporting that and making sure that we're adhering to those things. But otherwise, no, there's not any restrictions. Again, I think we just need to be in value-based care, you just really want to make sure that whatever test you're ordering is appropriate and necessary, specifically when you are considering what the patient wants, right? So, you know, for example, I had a 92-year-old patient, um, um, wasn't super healthy, and she had a belly mass that I knew of. And I explained to her that, you know, this was super concerning. And, you know, we really should, you know, consider getting imaging. She did not want it. And she was adamant about it. And her daughter also, you know, surprisingly, because usually there's a, you know, there's a usually a dynamic, an argument between what child wants, a disagreement between what child wants, what parent wants. And they were both pretty adamant and said, no, she just wants to enjoy her life right now. She doesn't want the stress of knowing what this is or have to go through any procedures to figure it out. And we honor that, you know, so for us, it really is about knowing and understanding what matters most to our patients and using that as the catapult for any other decisions we make for them, with them.
And one more question in the chat. With regard to motivational interviewing, maybe you could take this one, Andrew. The question is motivational interviewing being used in communication with patients?
Motivational interviewing, I'm not fully understanding the
Okay.
I can respond.
there.
Yeah, I can respond to that. I think, you know, that's a really good question.
And what are the benefits? It's kind of like a two-part. If so, what are the benefits?
Yeah, so you know, I came from a integrated behavioral health background when I worked at the FQHC. So I'm very familiar with motivational interviewing. I don't think it's a practice that we learned in medical school or that probably learned in APP training, but it is something that our LCSWs who we have on staff are obviously very well trained in. And so when we consider patients that are maybe non-adherent to our management advice or treatment plans, or a patient where, you know, they may, like in the case of this 92-year-old who didn't want anything done, but maybe if she was a lot younger, you know, and we were trying to really convince her, you know, to get it done because she could have better outcomes, you know, we can refer those patients to LCSW to dig a little deeper and figure out what the resistance is, to see if we can affect, you know, their decisions. I don't know if that was what you were looking for.
Well, thanks for taking that one. Yes, or the person who asked said yes, it is. Thank you. So let's go back to you, Andrew, for just a minute and talk about kind of the future. We talked a lot about what we do and what value-based care is and how, you know, how we function in the value-based care environment and what it all means. How do you see the evolution of value-based care maybe affecting patient care standards or, you know, the medical profession?
So I think this is a shift that's inevitable, to be honest. I think the fee for service model is um, greatly flawed because it really takes the individual and the kind of relationship away from the patient and the provider. This value-based care model, this risk adjustment model really allows us to have a much bigger kind of global understanding of how to take care of these patients, both from a treatment perspective, but also as a prevention perspective. I think it is going to be the future of long-term Medicare managed patients. I'll tell you a small tidbit of the data analytics allows us to be more fluid on how we approach this. The data is constantly coming in, and it's not just data, it's meaningful data. And when you use that meaningful data, you can then kind of redistribute resources, focus on areas that have been lacking, and then track their actual outcomes. So that is a strong tool for us. And I think, to be honest, it's been beyond helpful to kind of understand whether or not we truly are making an impact on the both the subjective and the objective approach.
Do you want to add anything to that, Dr. Stewart?
What I will say, I know I just saw something pop up about the V28 changes.
Yeah, I
So
was going to bring that up.
yeah, so Medicare did recently, well, last year proposed, you know, changes to the reimbursement for the high risk conditions. And these changes are happening over the next several years. What we do know is that the conditions that we're being reimbursed for right now will change. And, you know, we're probably going to be getting, and we know we'll be getting lower reimbursement. But we are positioned very well to handle these changes because we've been implementing services, and some of them we spoke about today, that really do provide high value. And they are demonstrating, you know, favorable trends in utilization. One of the things that we've implemented is our e-consult services, and it's great. It's peer-to-peer consultation services, and it allows us to communicate with the specialist directly and get recommendations within 24 hours. Okay, so the patients don't have to worry about co-pays. They don't have to worry about travel to that provider, the transportation, the headache that comes along with it. And it also reduces just the weight on the answers you're looking for, right? So in our area, for some of the specialists, it can take up to 3 months to get an initial visit, an initial evaluation. And it also, this service, because it's peer-to-peer, you get an answer within 24 hours. A lot of the conditions we're dealing with, you know, they're heavy on, you know, diagnostic results or labs or, you know, a simple history. They could give us a lot of what we need right then and there, and it keeps the PCP in the driver's seat. So I think, you know, I think that is a great service. And then we have our integrated behavioral health that I think is really important in this landscape. So, you know, as we know, the highest cost patients and the top utilizers very often have serious mental illnesses or undiagnosed behavioral health conditions, or it's the social determinants of health that are, you know, really driving up these costs. So when we partner with we have a partner in behavioral health. When we partner with our behavioral health colleagues, we're able to really affect those numbers. I just don't think that it's enough anymore to, you know, write a script for evidence-based, you know, management and have them walk out of the office. I think like Andrew's been saying, we must wrap our arms around the patients. We have to partner with them. We have to address their medical needs. We have to address their behavioral needs. We have to address their social needs. And, you know, and I think that's how we're going to be successful.
Well, I think that I've covered everything that I had on my list I was wanting the two of you to talk about. Do either of you have any final thoughts? Andrew, was there anything motoring around in your head at the last there that you wanted to put in for the end of the talk?
I think as far as the specific to the V28 and the changes to reimbursement, it's been known and we are preparing. We've been preparing. And I think that's the biggest difference in the way we approach kind of the value-based care. We know it's coming, we're preparing for it. In this managed risk assessment scenario, you get this lump sum to take care of your patients, and that lump sum might be reduced based upon some of these reimbursement changes. However, the output, what's coming out of that lump sum, may also be greatly reduced because you may not need to send them to 5 different specialists. You have the resources to take care of them more in-house. We have diagnostics that are available to us. We've made great relationships with some of the specialists that we work with. All of that has allowed us to, reduce kind of the outflow that's coming from that pot, and I think that's a big kind of shift that if other fee for or other value-based care programs are not already planning for, they're going to be left behind aggressively.
I think that's just, to me, it's like I know about this, but to hear it actually talked about, it's actually kind of interesting. And I love the things that you've said about it. I also liked hearing Dr. Stewart say about keeping the PCP in the driver's seat. If you guys wouldn't mind doing just one more question that popped up in the chat here. Dr. Stewart, how do you manage a non-compliant patient in our model?
Yeah, so we have lots of those. So, there's, I guess it depends on why they're non-adherent, right? We got to figure out why they're non-adherent. So for that, if we're not able to figure out as a PCP, we have the option to include an LCSW or behavioral health if they're willing to discuss that. Secondly, we really believe in multiple touches. So what we'll do is, first of all, non-adherence can often be because a patient's just so overwhelmed by all of their diagnoses and all of their medications. So a lot of times you can just take it like one system at a time, like one chronic condition at a time, and get a good hold on that one and then move on to the next. And so, we can have multiple touches. Like I said, we can invite a patient to come into the office every week until we get it right, if we wanted to. And we can invite support. So we can have our nurse help out. We can have our pharmacist help out. I actually, I often reach out to my pharmacy colleague and say, hey, listen, take a look at this like 15 these 15 meds, and can you please let me know, is a patient actually taking them? And are there interactions that I'm missing here? And could you maybe run through the meds with this patient so they understand why they're taking them, and work on a regimen that is most helpful? And they come back with, they can come back with really great recommendations. Sometimes I will be honest, sometimes just talking it out. So we have high risk, our high risk calls with, which includes our care navigators, the nurses, and our community health workers. And at times we'll invite our pharmacist or the LCSWs, and the PCPs of that office are usually together on those calls. And sometimes it's really helpful to have another eye, right? Another provider take a look at the case and say, well, have you thought about this? And, maybe this is why they're not, following the instructions. So there are tons of resources that we can pull on to address some of the non-adherence, but I think there are so many reasons that a patient may be non-adherent. And sometimes patients just don't want to be honest with us. They want to satisfy us, and they don't want to be, they want to make their doctor happy. So they say they're taking something or they're doing something when really they just don't want to. And we have to figure out and learn why.
Well, Well, I loved hearing all that. That was very informative for me, and I appreciate you both sharing so much. Um, and I will get in touch with the person direct message that just sent to me. Um, do you have any final thoughts? I'm sorry, I was trying to make sure there weren't any other questions. Let's see, how do you incorporate? Okay, would you mind doing one more question before we go?
Yeah, sure. I think Andrew could handle that one since
Okay.
he's an APP.
Could you talk about incorporating nurse practitioners and PAs into our practice? Is there appointment rotation, or are they assigned to providers?
So we have a lot of autonomy. We have great resources at the facility that I work in. We have 3 MDs, 3 NPs, and 1 PA, and all of us are very comfortable with each other. Often, as many of my patients have been seeing me now for 5, 6 years, and they will not see anybody else for their chronic care management. However, I strongly encourage them when they have acute care issues that I trust my team members, and that they should have faith in us, and that I am also aware when my provider, my partners, my cohorts are communicative. They tell me, hey, I just saw one of your patients that you regularly see, and ultimately, this is what's going on. You know them very well. What do you think? What do you suspect? I had a specific example for you. One of my longtime patients, likely potential Alzheimer's disease, frontal temporal lobe dementia. She's really nonverbal. She's been losing weight, and it's been happening slowly but persistently. And nobody's really picked it up until the other day when I saw her, and I said, "Look, I've been watching the trends. It's noticeable that you're losing weight, and I'm concerned that you may have some swallow difficulties, or there may be some airway protection scenarios." And sure enough, all of that was, true to be found. And I was able to reach out to some of the MDs on the team and ask them what's the next step? Do we hospitalize this patient? Is there somebody in the outpatient world that we can reach out to get more of an acute care scenario, so we don't have to send them to the ER, because once they hit the ER, you lose them. I mean, you can track them, but you have no ability to intervene. And sometimes you know what your patients need, and ultimately the hospital's going to do what they want to do. So I would tell you that the nurse practitioner, the mid levels, if you wish to call us that, we are extremely skillful and well trained. We consistently get in services by reviewing a lot of the consultation notes from the specialists. We are able to see and treat things that we normally would not have treated in other facilities and other practices. So we are very well utilized. As far as appointment rotation, like I said, we have this open access program, which is fantastic. They try to leave a appointment slot or 2 for each of the providers, rotating depending on what the acute care needs are for some of these patients who are calling in, so we can keep them out of the urgent cares, keep them out of the ER. A lot of the times patients are comfortable only seeing one provider, so they're willing to wait for certain things of the sort. But other than that, I mean, it's I don't want to say it's a free for all, but you try to build your patient population and feel very comfortable with how it grows.
Thank you, Andrew. So I think we are kind of getting the end of our time here. Thank you so much, Dr. Stewart, Nurse Practitioner Andrew, for spending the time and giving such thorough answers to these questions. I know I've learned a lot. A lot of people on the call have expressed the same. And we will be sending the recorded version of this presentation out to everyone who registered. And I also wanted just a quick thank you to my friend, my colleague Valerie, for helping me put this together as well. So thanks everyone, and have a good night.
All right, thank you.
Thank you guys so
Bye.
much.
Bye-bye.